Hello, good evening everybody, and welcome to our talk on gynae health. Thank you everyone for joining us today. So we've got three speakers this evening who will be discussing gynae health. So we'll be covering smear tests and cervical cancer symptoms, PCOS and chronic pelvic pain, and what physiotherapy you can use to help relieve that. So my name is Brute. Obviously you can't see my face, only our presentation, so we thought we'd share photos of ourselves to kind of make us, so you know what we look like. In terms of this evening, I'm going to do a very brief introduction. We will talk about the self-pay options at BMI London Independent. We will then have a discussion on PCOS, how to diagnose it and manage it, smear tests and signs of cervical cancer, and physiotherapy to help manage chronic pelvic pain and painful sex. Just a little bit about BMI The London Independent. We are located in East London, within close proximity of the City, Canary Wharf and Essex. We recently have been ranked the #2 private hospital in the UK, which we're really proud of. We are also one of the very few private hospitals in the area to have an ITU, which means that we can do more complex procedures as and when needed. We kind of offer diagnostics, day case treatment and inpatient care, so kind of to look after you from start to finish. And we're really passionate about expanding our gynaecology offering and offering women kind of a comprehensive healthcare service. I just want to give everyone a little overview of our COVID response, because I know that people are really scared about attending hospitals, and just want to reassure you that we do kind of everything we can to make everybody safe, including our staff, our consultants and patients. So we are proud to offer a green site since the onset of the virus, which means that we haven't had any cross-contamination since the pandemic started. In terms of to keep us and you safe, so we limit the number of visitors we allow in the hospital. It is mandatory for everyone to wear face masks in the hospital, staff and patients alike. Those who are exempt from wearing a mask, we provide them with a visor, so again to just make sure that everyone's kept safe. We have extra hand sanitizer stations set around the hospital. All patients are asked to fill out screening questions before they see the consultants or go in for a procedure, and both staff and patients have daily temperature checks to just make sure that everyone's healthy when they come in. If you have any questions after this presentation, these are my contact details. So I'm Brute and Michaela as well, and she's the patient and consultant liaison officer. So she will be able to help you with any queries that you may have. And if you have any for any of our speakers today, we will also make sure we reach out to them and get you the answers you want. And now I'm going to introduce you to Michaela, who will just very briefly talk to you about self-pay.
Hi everyone, I'd like to just start by saying thank you for joining today. So just a little introduction about myself. My name is Michaela, I'm a self-pay lead here. I've been at the hospital for about 3-4 years now. Just a little bit about our self-pay packages. So all of our procedures, they all come under our fixed price packages, and they offer up to 6 months worth of aftercare. Sorry guys. So everything's included in our packages. So after you have the procedure, you only pay for the procedure. You don't get any invoices afterwards, and that includes any scans, any physio, the pre-assessments included, and the COVID swab. And to help make this even more affordable, we do offer payment plans. So we have 2 payment plans on our website. One's called the BMI card and the other is Chrysalis Finance. They both help you spread the cost over 12 months with 0 interest. If you want any more information on this, please feel free to drop me an email or give me a call, and I'm more than happy to go through it all. So yeah, my details are there. Any problems, or if you have any questions about anything else, just let us know. Thank you.
Thank you for listening to our brief introductions. We're now going to introduce our first speaker, Mr. Nnochiri. So for those who have signed up online, you may have seen that Sarah Dean, who was our Director of Clinical Services, was due to present to you on Polycystic Ovary Syndrome. But Mr. Nnochiri saved the day and stepped in for Sarah. So he's going to just be discussing polycystic ovary syndrome, how to manage it, and what symptoms to look out for. He's a gynecology consultant here at BMI, and just had an urgent call, so he's just running a bit late. But I'm just going to go through it and just show you a picture of him. This is him, so this is who you're talking to, and he's now back, so he'll just start the presentation.
Hello, good evening. My name is Nnochiri. I'm one of the gynecologists here, and I'm going to be talking to you this evening about polycystic ovarian syndrome. Of course, I wasn't supposed to give this talk, but I'm here now. So if you have any questions to ask as we go along, please feel free to do so. There are three main features of polycystic ovaries. One of them, importantly, is having irregular periods, where your periods may be delayed, and when they come, they become quite heavy, and some people may not even have a period for a very, very long time. And the simple reason for this is that you're not ovulating, and once you don't ovulate, then that cycle that you have every month doesn't really happen, and then your periods can be delayed. And once your periods are delayed, what it does do is that it increases the level of estrogen that your body produces. And that level of estrogen can now affect your male hormones, the way your body handles insulin, and all the things that can make problems or can cause problems with regards to polycystic ovaries. And those sort of problems, when your male hormones increase, you tend to have things like excess facial hair or body hair in certain areas, like male pattern hair. It becomes a bit of a problem, especially when you have oily skin, and then you may also have acne on the face. And some people may have hair, thinning hair, where your hair begins to recede or fall out as a result of this condition. To diagnose it, we tend to say you've got to have at least 2 features out of 3. And one of those features will be that you've had a scan which shows that there are polycystic ovaries. But that doesn't really mean that you've got any cysts on your ovaries. It's just that you've got tiny, tiny cysts in the ovaries which were supposed to be to produce some eggs, but then they don't really produce any egg, and they just stay fixed around the edges of your ovary. And that's what tends to happen. If you have that on scan, and also you have this delayed period, and then you may have some of these other symptoms that I talked about, then if you have 2 out of these 3 features, then one can say you possibly have polycystic ovarian syndrome. Having polycystic ovaries on its own is very different from having a syndrome. The syndrome is when you do have all the other things that I talked about earlier. We don't actually know what causes polycystic ovaries, though we know it can run in families. We know it's related to abnormal hormones in your body. One of them being insulin, and as you know, insulin is a hormone that controls blood sugar levels in your body. And when we have polycystic ovaries, these women can be resistant to the action of insulin in their bodies, and therefore they need to produce more insulin to try and overcome this effect. And of course, that can now lead to other things, such as having diabetes much earlier than they would have had otherwise. And of course, it's not everybody who has polycystic ovaries that is overweight, but at least more than 50% of people who have polycystic ovaries may have some weight problems. And when you look at polycystic ovaries, we do say that it is very difficult to know how many women would have it, but it's probably 1 in 5 to 1 in 10 women in the UK would have it. It means it's pretty common, and more than half of these women will have no symptoms at all. So if you do have a scan and someone says you've got polycystic ovaries, it doesn't necessarily mean that you've got the syndrome. As long as your periods are regular, which means you're ovulating, and you do not have any of the other symptoms that are described, such as the thinning of your hair, the facial spots, or increase in male pattern hair distribution, then you just carry on as normal. The only advice I would give such women is try and keep your weight and try not to add any weight if you can help it. We know there's no cure for polycystic ovaries, but we can definitely manage it. Like I said, more than 50% of people with polycystic ovaries will be overweight. So losing that weight, healthy eating habits, having a balanced diet, and general exercise will be able to get that weight down. And once that weight is down, most people would get their periods back, and some of those symptoms would go away. The management of polycystic ovaries depends really on what the particular patient wants to achieve, because it's a whole spectrum. You may have people who what they really want to do is just to have regular periods, and in those set of women, just the combined contraceptive pills, if they can do that, would help with that, because that will also help to suppress the effect of the hormones and reverse some of those the symptoms as a result of high male hormone level called testosterone. But mostly we tend to see women who come in because they are trying to have a baby, and if that's the case, then we would need to tailor their management in a different way. We would need to, as I mentioned earlier, one of the reasons why you don't have a period is because you're not ovulating. So the key thing will be to help them ovulate, because of course when you ovulate, 14 plus or minus 1 day after the day you ovulate, you would definitely have a period. So if you do ovulate, then you would have regular periods. And there are ways in which this can be achieved. This could be weight loss, as we said earlier, which will get your periods back and hopefully make you ovulate, and then you can go ahead and get pregnant if everything else it's okay. Or we could give you some medication one of them is called clomiphene citrate, which we tend to give. We tend to give it within the first week of your cycle. For just 5 days in that cycle, and we can give it up to 6 months, and that would help you ovulate in that time, and hopefully we'll be able to get pregnant. But it's important to know as well that when you give medication that helps you to ovulate, that in about 10% of women there's always that small risk of multiple pregnancy, where you may have a set of twins or triplets. Not that it's not desirable, but not many people are ready for that. So you need to be aware of that as well. But in terms of people whose main symptom has got to do with male hair distribution, then there are other methods in which that can help. We could use medication such as the contraceptive pill that can help. You could also add particularly certain pills, something like Yasmin, because it contains a medication called spironolactone, which is anti-male hormones and tries to reduce the amount of male hormones you have, and by inference, consequence of that would be that you would reduce the hair growth. You could also do some cosmetic measures like shaving, which is what most women do. Electrolysis, laser treatment, but in the main, a combination of medical management and cosmetic management would get better results. I'm sure a few of you may have heard something about metformin. I left it to the last because it's not licensed for treatment of people with polycystic ovaries, but we know that it has certain benefits, and those benefits, it's helping to reduce the amount of insulin in the system, and by reducing the amount of insulin, it basically lets the ovaries breathe a little bit, and therefore hopefully start to ovulate. But then the question is, how long are we going to give it for? Does it have any long-term benefits in terms of the long-term consequences of polycystic ovaries? We really don't have any evidence for that at the moment. Okay. Right. So and then we don't really have any evidence that could work long term. But having said that, I think one of the things people need to know about polycystic ovaries is the long-term consequences of polycystic ovaries. And those things will be, one of the things I mentioned earlier is diabetes, type 2 diabetes, coming up a little bit, maybe 10, 15 years earlier than it would have come. High cholesterol, increase in cardiovascular diseases, and therefore it's really, really important that at least weight loss is one thing that we can, we have control over. I know it's more difficult when you've got polycystic ovaries to be able to lose weight, and that is where GPs can come in to you know, give you, refer you appropriately. Most of the fads and diet, you know, dietary fads probably don't work long term, but having joining groups and being able to control that, having a dietitian and all that, and you know, having pair groups that you exercise together, or taking regular walks every day, just 3-4 exercise episodes a week, about 30 minutes every day, in that time would actually help lose significant weight, which can reverse the effects of polycystic ovaries.
So we just have a few questions. The first one was, can you be undiagnosed with PCOS? I was diagnosed 13 years ago, but recently my testosterone was a normal range and no cyst could be seen on ultrasound, and my diagnosis was questioned.
I think one question I'll say is, the time you were diagnosed with polycystic ovaries, did you have any of those other symptoms that were described, which is where your periods delayed, were you ovulating regularly? Did you have any of those other symptoms to make that diagnosis? What tends to happen mostly, especially with the increase of the use of ultrasound scans, is that we tend to diagnose polycystic ovaries more commonly than they are. The fact that you've seen multiple cysts in someone's ovary does not mean that they've got polycystic ovarian syndrome. You may have a polycystic looking ovary, but you don't have any, your periods are regular, you don't have any male hair distribution, no hair loss, no acne, none of those other symptoms, you're ovulating regularly, then you don't have polycystic ovarian syndrome. It may also be that maybe lifestyle changes, weight loss, exercise, and all that may well have reversed you know, because I said once you drop that weight, you reduce the amount of extra insulin in your system, and releasing that extra load of insulin lets your ovaries breathe, and then your cycle kicks in. You know, your hormones work in sync, and working in sync means that most of the follicles within your ovary would actually form eggs in the end. Therefore, you do not have those small cysts that are there that do not actually ovulate, but then give you that polycystic. So the answer to your question is yes, it can be reversed, but I think something would have happened to make it reverse that.
And we have one more question. It says, I've seen that women suggest cutting out dairy and gluten to help with PCOS. Is there any fact to this?
Yes and no. I don't think it's the gluten or that, but I do think that balanced diet, the right amount of diet, can only be useful. Because if you do have some gluten allergy or things like that, you find that you feel bloated all the time. But you know, in terms of the science of what we know about polycystic ovaries, I do not think that coconut gluten would affect that. But losing weight or eating the right amount of food and getting your system working right, reducing the level of insulin that's within your bloodstream, that would definitely affect polycystic ovaries in terms of your symptoms.
That's it, no more questions. Thank you
very much.
Thank you so much to Mr. Nnochiri for stepping in and saving the day. I think that was really useful, and if you have any more questions, please type them in. We can always drop him an email and ask for them, and then we can get back with a response to you. So next we've got Marta, who will be talking about physiotherapy for pelvic pain and pain kind of during sex. So I will just let her share her presentation. Marta's been a physiotherapist for 11 years and has been a specifically women's health physiotherapist for 6 years. So it's really exciting for us to listen to her speak. So if you just give us a couple of minutes for just a couple of seconds for the presentation to come up, and I'll let her start.
Hi, Birut.
Hi.
Can you hear me?
Yes, we can hear you.
Great. Thank you, Mr. Nnochiri, for your presentation. It was very interesting. And hello, everyone. My name is Marta, and I'm a women's health physiotherapist. I'm not sure if you can see my slides now. Hopefully, yes. Okay, and I'm great. Thank you. It's very difficult to be doing this without seeing people. So this presentation today is about women's health physiotherapy for the management of chronic pelvic pain and painful intercourse. And so in the next 20 minutes, roughly, I'm going to talk a little bit about chronic pelvic pain, how common it is and some of the causes. I'm going to be talking about the pelvic floor muscles, which are related and can become dysfunctional because of chronic pelvic pain, and the link between a dysfunction in the pelvic floor muscles and painful intercourse. And I'm also going to be talking about how women's health physiotherapy can help in these cases. So it is important to say that chronic pelvic pain is any pain in the pelvic area that lasts for more than 6 months. Sometimes we know the cause of the pain, but sometimes the cause is not obvious. And sometimes the original problem, the initial injury, has been treated, but the pain still persists. It is also important to differentiate between acute and chronic pain. So acute pain is a sudden pain that starts because of an injury or a condition, and this is pain that needs to be treated, for instance, if it's appendicitis. However, chronic pain is the type of pain where the initial problem has been treated, but the pain still persists after a long time. And we know, unfortunately, it's very common. Roughly around 25 million women suffer with chronic pelvic pain. We know that around 25% of women with chronic pelvic pain spend around 2 to 3 days in bed each month. So women with this type of symptoms are missing work or not going to school and are just avoiding exercise and being deeply affected by this symptom. We also know that 90% of women have pain with intercourse, and that around 50% of women with chronic pelvic pain feel sad or depressed at some point in time. There are many causes for chronic pelvic pain, and it's important to see the GP, a consultant, a gynecologist, a urologist, or a gastroenterologist, depending on the type of symptom, because these conditions can be gynaecological conditions, such as endometriosis or just painful periods, but it can also affect the be related to problems in the digestive system, such as irritable bowel syndrome or problems affecting the urinary system, as in painful bladder syndrome and interstitial cystitis. And these are just some examples. Chronic pelvic pain can also be caused by musculoskeletal problems, so problems affecting the pelvic joints, such as coccyx pain, pain around the hips, pain around the lower back as well. And there are links between post-traumatic stress disorder and depression linked to chronic pelvic pain symptoms as well. Sometimes patients ask, well, my problem is in the pelvis, but I do feel the pain elsewhere in my body, so like around the perineum and the genitals, or on the lower back or around the legs. And this is because it's linked to excessive muscle tension. And the excessive muscle tension and the pain can be caused because of referred pain coming from the organs, but also because of excessive guarding of the muscles around the area to protect the area. And this is very much linked to the flight or fight response. So if there's a threat, traumatic event, or a very painful condition, the muscles around the area tend to get tight, as if they're bracing and locking the area to protect it against pain. And this is very easy to understand. So for instance, if we see a lion or if we're under a threat, our posture kind of changes. We tend to, the muscles around the jaw, the shoulders, the muscles around the stomach and the pelvic floor, we tend to tense them. The muscles around the hip joints, so to be able to run away or fight if we need to. And that's very much what happens when we're under a lot of pain. We also tend to adopt a position like we're curved and bracing around the stomach because there's where the pain is. And we tend to hold the breath a lot. And this is compensatory strategy, but in a long term, this can also affect the muscles. They weren't designed to be tensing so much. They can get tired and develop painful points as well. And that pain can then create a vicious cycle, because if the muscles start complaining and the joints start complaining because there's pain, then the brain just perceives that, oh, there's really a problem. I have to keep tensing these muscles to protect myself against pain. And then it creates a vicious cycle. Obviously, the muscles that are more affected when we talk about chronic pelvic pain are the muscles of the pelvic floor and the muscles of the core and around the abdomen. I don't know if you can see well, but so the pelvic floor muscles, they're the layer of muscles at the base of the spine. They start on the front of the pubic bone, and then they attach on the tailbone on the back. And this is a lateral view of the hip on the first picture. So these muscles are very important because they help us control incontinence. So they squeeze around the sphincters, around the front and the back passage to help us holding urine, wind and stools. But they also have to be able to fully let go to allow us to empty properly the bladder and the bowels. They also give support to the pelvic organs when we jump, when we lift weights. They just kind of tighten to keep things in place. And they're also important because for sexual function, and I'll develop a bit more on that in a minute, because we also need to talk about another important function of these muscles, which is they're part of the core. And then on the second picture, we can see that they've worked together with the deep tummy muscles, the deep abdominal muscles, the lower back muscles, and the diaphragm. So they're part of the core, and these muscles should all work together to help create good stability and help with all the functions I mentioned before. Now, these muscles behave like any other muscles in the body. They can get tight, they can get weak, they can get shortened, they can develop painful points. And if there's dysfunction in these muscles, we can have symptoms affecting all the functions I mentioned before. This is just a slide with an internal view of the pelvic floor muscles. So they're like a hammock at the base of the spine. And talking more specifically about sexual function and why they're involved in sex, is that these are the muscles around the entrance of the vagina and the back passage. So during sex, if these muscles are healthy, they're able to stretch without any pain. So they're able to relax and stretch and allow penetration without causing any pain. Now, if these muscles are overactive and tight and bracing, sex can become painful. So it is important to say, and we're talking about intercourse being painful in relation to these muscles, when we know that there's no obvious gynecological reason or pathology or disease causing the pain to be there. If it's related to the muscles, patients often have been checked by gynecologists and the GP, and we know there's no condition causing a problem. And what we know is that during penetration, these muscles are very tight. They feel like a wall. They don't want to be stretched. And just a minimal attempt of stretch. And this can be during penetration, but also, for instance, when inserting a tampon or doing a pelvic examination for a smear test. If these muscles are overactive and really tight, we will have pain when attempting to stretch. And sometimes this is something that just telling a patient to relax is not enough. Because when the muscles have been working in this bracing mode for such a long time, what happens is that the brain loses the ability of relaxing the muscles. It's kind of as if the brain has forgotten how to fully relax these muscles. And also because there's the fear of what's going to happen next, it's going to cause more pain. And with that fear, no muscle in the body is going to relax. It's the same thing I often tell, because patients say, well, but I'm trying everything I can to relax. And I often say, it's as if someone is stabbing us with a knife. We're not going to relax, because the body, the brain, and every time I say the brain is not because it's psychological, it's just how we were wired for survival. The brain is not going to allow the muscles to relax because there's a threat. And so this becomes a vicious cycle. And the next slide just shows this cycle very well, where there's a pain experience, and can be a painful experience with intercourse, or it can be pelvic pain and discomfort around the area. The attempt to, the idea of there's something quite not right, and the brain starts worrying about it. And then what we say is that there's a hypervigilance of the central nervous system, as if, okay, everything that, such as sex, a smear test, anything that can possibly cause a stretch or discomfort in the area, it's like the body will try to avoid. And this will cause negative emotions such as fear, stress, and in terms of intercourse is knowing the expectations of the partner, knowing that the partner will be sad or upset, and not knowing what is going on. And then this leads to penetration avoidance, and this is often because it's the fear of pain. So we know this is because the muscles are overactive and they're not really letting go, and they need to be taught and trained as any other muscle to relax, and they need to be rehabilitated. Now, with sex, I also tell my patients that it's not only about muscles. So of course, being aroused is an important part of sex, and this is also interesting when we talk for men. If they're not aroused, they can't have sex, whereas unless they take medication for it. Whereas women, when they're not aroused, they say like, oh, I could try. And then the experience is uncomfortable and causes more pain. And then this leads to a whole vicious cycle. Okay, so in terms of how women's health physiotherapy can help. So physiotherapists work with patients to help retraining the muscles and to get them independent and regain function. So this specific type of physiotherapy is a physiotherapy that focuses on the pelvic floor muscles and abdominal muscles. So if you're struggling with a problem like this, the best physiotherapy to see you is a women's health or a men's health, because men have a pelvic floor too, or a pelvic health physiotherapist, because we're trained to treat these muscles properly. And so the goal is really with each patient, because everyone is different, is to understand what is causing the chronic pelvic pain, if it's being well managed from a medical point of view, understand how the bladder, the bowels are working, and then understand how the pelvic floor muscles and abdominal muscles are working. And then we also teach our patients strategies that they can do at home to help reducing the symptoms and managing the symptoms. So a women's health physiotherapy consultation usually involves a detailed subjective assessment where the physiotherapist just has a conversation with the patient to understand, again, what are the triggers, when do the problems start, how is this problem affecting you, and what are the nature of the symptoms, and what are the contributing factors that we can just change using simple lifestyle changes. Of course, this is a very confidential process, because there's a lot of confidential information that is disclosed by patients during assessments. The second part of the assessment is usually a physical examination, and we first assess how externally, how the pelvic joints, the lower back, and all the muscles around are working, and we assess posture, how the patient moves, if it's holding the breath, tensing excessively the muscles around these joints, general muscle strength and flexibility, and the areas of the pain. And then there's a second part of the initial examination that may or may not involve an internal pelvic floor examination. And I say this, so ideally, if we have pelvic floor pain and painful intercourse, assessing the pelvic floor muscles internally, either rectally or vaginally, is an important thing. But not all patients feel comfortable to have internal examinations. So we can find strategies to address each patient concerns and create a program based on that. When physiotherapists do an internal examination, I say this because it's the most important thing, it's never a painful experience. There might be a little bit of pain or discomfort, but this is always low level, because the main goal is to retrain these muscles and to teach these muscles how to let go. So if there's pain involved in an examination, again, no way the muscles are going to relax. So it's important to create a safe environment, and then to examine these examinations, it's usually a digital palpation, so we don't use instruments, and the goal is to see if the muscles are tight, if the muscles can squeeze and relax properly, how strong they are, how weak they are, if we can squeeze and hold, and if there's any other signs that could potentially be the source of pain. After we gather all this information, we create a tailored treatment plan that involves self-management strategies, stretches, relaxation techniques, breathing exercises, and self-massage techniques to kind of create a steady program that will lead to change in the way these muscles work over time. In many cases, physiotherapy alone is not enough. So if there are traumatic experiences, if patients have been struggling with this problem for a long time, we might see the patients and refer them to psychologists, psychosexual therapists, consultants as well, if we see that there's something else that needs to be addressed. And the important message here is that usually it's a condition that requires a multidisciplinary approach. This is just a short list of things we see, of conditions we treat here at the BMI London Independent Hospital. I know some of the names are a bit scary, but so these are just a few conditions that can affect the pelvic floor, and it can be related to urogynecological symptoms. It can be related to pregnancy and the postpartum. It can be related to chronic pelvic pain syndromes, as we covered just now, but also related to colorectal problems. And then this is a picture of myself and my colleague Magdalena. So we work here and we see our patients here at the BMI London Independent Hospital. We are able to see patients under a consultant referral or self-referral. If you have a health insurance, we're covered by most of the medical health insurances, which is quite great, but we also see patients privately. And the waiting lists at the moment are well managed between myself and Marta, and that's it. And if you ever meet us, we'll be here happy to meet you. If you have any questions, feel free to ask us, and thank you for your attention.
Hi Marta, we have a few questions.
Yes, do you want me to stop sharing the screen, or should I just leave it here? Yeah? Yeah?
Yes, that's fine. So, can pelvic pain from pregnancy STD last forever?
Sorry, Birute, I think I lost you.
Can pelvic from pregnancy last forever?
Yes, so it can if it's not well treated, yes. And I wouldn't say last forever, as in it won't ever go away, but it can be, even if the pregnancy was 10 years ago, if it wasn't treated, there still can be problems related to that pregnancy. So seeing a physiotherapist is actually a good thing. And I often say to my patients that actually postpartum is forever. So because I sometimes see patients say, well, but I had my baby a long time ago, this surely is not related to pregnancy. But yes, pregnancy is a significant event in a woman's life, and childbirth too. And the body needs to be rehabilitated afterwards as well. So there's the case of, if you have a knee surgery, you see a physiotherapist to retrain the muscles around the joint. If you're pregnant and have a child, it should be mandatory to see a physiotherapist as well for an assessment and then treatment if needed.
Great, we have one more question. So, would a consultant gynaecologist assess pelvic floor? I get pelvic pain so severe I vomit and pass out, both with periods and without. The consultant has put me on Cerazette until I have an appointment and said he wants to examine me. I've already had a clear laparoscopy, so I'm not sure what is left to check. I'm really nervous about it. So just 1 second, I've just muted you accidentally. Can you unmute yourself?
Yeah.
Yeah, there we go.
Can you hear me? Yeah. I am sorry to hear this. Pelvic pain can be excruciating and very debilitating. So I think the first step is to really do all the further investigation needed. And I think I understand this is happening. And once the results are clear and the consultant is happy, definitely physiotherapy can help managing this pelvic pain. And this is just with a set of strategies to help releasing the muscles around, which are contributing to pain as well, and also changing lifestyle and teaching patients specific strategies that can help during these times. But I think the first step is really to make sure that the consultant, to see a consultant and to do everything to exclude any other conditions that can be causing the problem. I hope I answered the question.
I'm sure they let us know if not, but we have some more questions. It says, can this be treated after 10 years? It causes a disability.
Can you repeat?
Can this be treated after 10 years? It causes a disability.
Yes, it can. And even if it's not fully resolved, physiotherapy is an important piece of the puzzle. And we can just give strategies to patients to feel better and to help managing the symptoms.
Right, and then one more. What do the NICE guidelines say about CPP?
Well, that's a very comprehensive question. But yeah, I haven't checked the guidelines recently, but I do have a very positive thing to say about pelvic floor dysfunction. So we currently have new guidelines being made on how to address pelvic floor dysfunction, and NICE is looking at ways to prevent it and to treat it in a conservative point of view, where physiotherapy is women's health physiotherapy is definitely a strategy to support these patients, to avoid then having patients being put forward for surgeries that they don't need. So NICE guidelines is working on supporting women after birth, women who have already symptoms of pelvic floor dysfunction, and I think we're going to be seeing these guidelines coming in this year or in the next year. There's definitely a strong work being done into supporting and improving women's health and women's care.
Great, that was all the questions. Thank you so much for your time. If anyone has any more questions and they type them in, I'll just ask you before the end of the evening. But thank you very much, Marta. That was great. Okay, so next we're going to introduce our gynecology consultant, Debjani Mukhopadhyay. I'm sorry if I said that wrong. So she's one of the consultants here at BMI, and she'll be talking about a cervical screening. So the process of smear test, showing just how simple and hopefully not so scary it is, and the symptoms for cervical cancer. We have had a few questions on PCOS for Mr. Nnochiri, which he wasn't able to answer before he had to rush off. But I'll just read out one of them and his response that he messaged us. So it was, what's a sign you're ovulating regularly? When I was diagnosed, I was having heavy periods, but they were regular. My ultrasound did show I had cysts on both ovaries. Does this mean I'm more likely to be infertile? And his response was, no, not if you're having regular periods. If you have regular cycles, that means you're ovulating, but an ovulation kit can always test this. It may be best to find out why you're having heavy bleeding, but this could be unrelated to PCOS. The other question was, I have PCOS, I'm on a combined pill but want to come off it as I have no sex drive. I'm not looking to get pregnant. Is there an option for me to come off the pill and manage my acne, hair growth and period regularly without the pill? So so he did respond, just 1 second. Yes, absolutely. Depending on your BMI or your weight, you can come off the pill, but every 3 to 4 months, progesterone can induce bleeding even if there's no period. This is not a method of contraception. Hair growth can be controlled with anti-male hormone drugs, but yes, it can definitely be managed by coming off the pill. We had a follow-up question to this that says, can I add that without the pill? My period stopped completely. I get excess hair and acne. I have tried the copper cord previously. So we didn't follow up with him on that, but as Debjani is joining us now, and she can unmute her mic, then hopefully she'll be able to answer that question for us. Sorry. Can you just click unmute, Debjani? There you go.
Yeah.
Hi.
Can you see me and hear me?
Oh, we can see your slides. So if you just display them in a big presentation mode, it will be great. Perfect.
Good evening, everyone. I'm Debjani Mukhopadhyay. I'm one of the consultant gynecologists currently working at Queen's Hospital and also at BMI. Thank you, Marta, and thank you, Akko. Your presentations were excellent. I'm just going to start with where is the cervix, because we're all dealing with cervical smears. And I think I just want to start with the beginning. So we all are clear on what I'm talking about, because it is a part of the body that we normally do not see. So explained in that picture, that big green bracket is the uterus. Now, uterus or the womb in a common language, the neck of the womb is the cervix, i.e. it's the bottom end of the womb. It is actually a part of the womb. It is continuous with the womb on the top. The tip of the cervix is visible from the vagina and it protrudes into it. The small green bracket is the vagina. So you can see that it is well hidden inside us. Starting from the cervical screening program. Now, as we know, the cervix or neck of the womb is hidden from the side. It is very difficult to monitor if something abnormal is happening there. And what is the screening program all about? It is about preventing cancer. And why is it so important? Because the common age for cervical cancer is 35 to 45 years of age. And 14 out of every 100 women beyond the age of 50 might even get it. The most important thing is it is one of the cancers that we can prevent, because it just doesn't become from normal to cancer. It becomes normal to pre-cancer to cancer. And it is, if we can stop it at the pre-cancer level, we've won the battle. Now, cervical cancer is the biggest killer of the women in developing countries. I wanted to bring this up. I think only then would you understand how fortunate we are. About 60% of women in India who have cervical cancer die because they're unaware of it, nobody's screening them, and by the time they're detected, it's a bit too late. Hence, I really want all of you to appreciate the significance and be grateful that we have a very robust cervical screening program. Now, what do we do in it? We are monitoring the cervix or the cells in the cervix every 3 years between the ages of 25 to 50 and every 5 years between the ages of 50 to 65. What is this monitoring for? Again, to pick up any abnormal cells. They could be low on the pre-malignant side or high on the pre-malignant side, but it is that pre-malignant part that we want to catch and treat before it becomes a cancer. An important thing is, a pre-cancer, when treated, you go back to normal. But when we treat a cancer, you kind of do not go back to normal. You're kind of monitored on, and it's kind of a stigma. It kind of in the back of your mind that it may come back. Now, I understand from many of the women I see, there is the fear about going to a cervical smear. I think the commonest reason for not attending a cervical smear would be pain. I really, really want to help you understand that a comfortable couch is where to start with. It's not the most dignified posture, I give you that, I'm a woman myself, but it starts with comfort. As you can see the couch in the picture, that's our BMI room. It's a very, very comfortable couch where you can lay back. The legs, of course, are apart as if you're having a baby. There's hand support there, but it relaxes the back. And just as Marta was talking in her talk, it relaxes the pelvic muscles because the back is relaxed, the belly is relaxed, the legs are relaxed. So it opens up the pelvic muscles. At this point, if I am inserting something in your private parts, it's a bit more bearable. Second fear is about the instruments that we use to take a smear. Now, I've kept that hand just to compare how big the instruments really are. It's a plastic speculum, disposable, so no fear, it's one use only. This is a normal size. It fits most, but we do not take it for granted that one fits all. This is what normally a nurse in a GP surgery, etc., would be using to take a smear. We've also got a smaller size, and this is for those who cannot cope with a bigger speculum. So we as women got to help women, right? And I think with a comfortable couch, with a proper size instrument, I want you all to get rid of that fear and come for your cervical smear tests. Now, this is a video and I'm going to play it in a minute, but let me describe what I'm doing. In my left hand is a plastic cervix. That's exactly what I see through the speculum, that little knob. In my right hand is the brush that we take a smear from. Now, can you see the pointy tip that goes inside that little opening in your cervix? That opening in the cervix, which we call os, is actually communicating directly to the womb. I don't need to go all the way to the womb. I just need to get a few cells or scrape off a few cells from the outer surface, which I can see, and also a little bit from the tunnel inside, which I can't see. So I'm going to play it for you. What we normally do is insert the pointy tip inside your cervix, make 5 circular turns, 360 degrees, scrape off a few cells from the outside, the inside, put it in a very special liquid solution. Now, this takes less than a minute, even if I did it 5 times. So going back, you've got a comfortable couch, you've got a speculum of all sizes, you've got a procedure that takes less than a minute. This is a special brush when the opening is very narrow or I really need to go deep inside and get a few better cells. This is what we use. And that again took a few seconds. Smear results. Now, smear's been taken, I've scraped off the cells, I've put it in the solution that goes to the lab. What the lab does is it centrifuges it. What it means is we put the liquid in a special machine, it speeds it up in such a way that it separates the liquid from the cells. We harvest those cells, we put it on a slide and we look under a microscope. And this is what we categorize the results as. So I've put in the 3 green and 3 in amber or orange. Now, normal, we all know what is normal. That's the best result ever. What that makes you come for a smear in the 3 years later. Borderline, exactly what the name means. It's on the edge, you know, not nearly normal, but not quite normal. Then comes the mild. If you were to, speaking a bit more scientifically, it all depends, you know, each cell is made of a nucleus and a cytoplasm, or the bit surrounding the nucleus. If the nucleus is bigger, it is bad. So it is the size of the nucleus in comparison to the cytoplasm around it that we grade it as mild, moderate, and severe. Now the blue means, the green means that I'm not worried about them. They are more likely to go back to normal sooner or later. The moderate, severe, and glandular changes. Glandular changes is, so the lining of the canal inside the cervix is a bit special, it's a bit different. It bleeds easily, it's a bit more friable, fragile, and the cells or the lining of the cervix outside, which we can visualize in the vagina, is a bit more turdy or hard. To give you an example, our cheek, the skin of the cheek and the internal lining is quite soft, isn't it? It's exactly the same way. So outside it's quite tough, inside it's quite soft. If there are changes in the cells within the canal, that's worrying too. So I've left them as amber because this is where my worry starts. This is what I need to, these are the women I need to kind of pick up in these clinics to be able to treat them before they get to cancer. And sometimes, of course, there is suspicion of cancer on the smear tests. Now, if the smear is abnormal, this is where you get referred. It's a colposcopy clinic. Now, I call colposcopy a prevention clinic, and we all know prevention is better than cure. Do you know that there has been research done on anxiety of women attending these clinics? And I think that's why I'm very keen to alleviate your fear in all way possible. I go back to what I started with. I want that to reiterate that we have a comfy couch, different sizes of speculums, and a very quick procedure. So now you've come to a colposcopy clinic, and what is my aim? My aim is to prevent you developing a cancer by detecting any abnormal cells and then treating it. So the picture is kind of almost like what we've got in our BMI clinic room. So there's the comfy couch, there's the lady lying, there's me between the legs looking with a microscope into her cervix, and you can watch on a monitor. Now, needless I say that a picture is worth 1,000 words. I always encourage women to have a look on the monitor, but of course, it's a choice. When you look at the monitor, it helps me to explain the extent of the abnormality that I am able to see. I think seeing is believing. If you don't see and I say, just a little bit, you would probably walk away thinking, I wonder what her little bit is. But if it is on the screen and I show you, you kind of make sense of it in your own way. And it is at the end of the day, your body. Again, going back to it, we have a comfortable couch, we have a speculum inserted, just like a smear test. We examine, we put some weak vinegar solution, we call it 5% acetic acid, and that kind of brings up the abnormal cells. It makes it very white. And sometimes we also use iodine. So we put in substances on the cervix, but we're only looking through a microscope to understand which are the abnormal areas. If I want to, I might take a biopsy if I'm worried about it, or I'm not quite sure, or I need a definite diagnosis. If, of course, it is severe or evidence of cancer or glandular changes, which I can't really see with naked eyes because it's hidden within the canal, we would go ahead and do a loop biopsy. I'm not going to talk about it because the talk of today is to attend the cervical smear. But I thought I'd let you know about a little bit more of what happens if the smear is abnormal. Now, coming to the risk factors, the most important thing, this is something that we can always assess ourselves on, or have a bit of control of preventing it. HPV. You know, the cervical smear tests now have gone back to testing HPV only. So the smear tests I do, people not only look at the cells, but also look at the HPV. So if the women do not have HPV or the human papilloma virus, they are considered risk-free or minimal risk from the virus or to develop this cancer. Human papilloma virus, people are very, very afraid of this word as well, HPV. And this is what I perceive from the patients I see. But let me tell you, it is present in 80% of all sexually active people. But with good immunity, though, we can get rid of it. What is good immunity? Probably a healthy lifestyle, vitamin D. You Google up, you see many things of how to boost your immunity, but basically being fit and well. Therefore, HPV will thrive in women with a weak immunity. So if you've got HIV, lupus, you're on steroids, some women who have had transplant surgery because they are on drugs that keeps their immunity low because it is someone else's kidney in their body, they are at a higher risk of keeping this virus or kind of harboring this virus in their body. Going back, women who have mild abnormality in the smear tests and have HPV, I always advise them to develop a healthy lifestyle. They are followed back in a year's time, and I've had many such women who've gone back to normal and gotten rid of us. Second, it is a modern practice of even letting some of the moderate smears some time to get rid of the virus and change the moderate back to normal. We do that in women who are under the age of 30, who've not had children, small area of disease. There are some criteria for it, but we don't offer them a treatment straight away. So even up to moderate, we are able to get them back to a normal with just good lifestyle. Smoking, I've written it in capitals because this is something that I've got evidence for, and HPV, of course, that are associated with abnormal cells as well as development of cancer. Some other points are starting sexual activity at a younger age. It is, HPV is a sexually transmitted virus, and it usually goes through. So when the cervix is exposed to intercourse, there are some cracks on the surface of the cervix, and it is through those cracks that HPV goes inside. So the earlier you start, the longer you are exposed to sex or in other words, HPV. Many sexual partners, it is very difficult to detect HPV. It doesn't usually cause symptoms. And it doesn't usually cause symptoms in males either. So condoms, using condoms as females is, using condoms as a contraception is a very, very important factor, especially if we are young and we do not have a steady partner. Having children at a young age, again, I think it's to do with more exposure to sex at a younger age. Symptoms, what are you looking for? What would you be educating to your other friends and family now that you go away? Any abnormal bleeding during intercourse, we call it post-coital bleeding. This is a telltale sign of cervical cancer. And if you have that, you got to go to your GP and get yourself checked out. Sometimes also intermenstrual bleeding, which means you're having irregular periods, but you're having a bit of bleeding in between. These are the two symptoms for young women to go to your GP and ask for some advice or a referral to be checked out. Postmenopausal bleeding. Again, bleeding when you shouldn't be bleeding is a telltale sign of cancer. Unusual vaginal discharge. I haven't got the time, but I've got experiences or stories of each of these symptoms and how the women did not think it was important. And by the time they've come to me, it was pretty advanced. Discomfort or pain during sexual intercourse. most important thing, when you've got intermenstrual or postcoital bleeding, examination, of course, is important because it is hidden well inside. Second is we need to exclude another quite curable but sinister cause of these symptoms is sexually transmitted diseases, i.e. chlamydia, gonorrhea, or even sometimes trichomonas. So you need some swabs to be done to exclude other sexually transmitted diseases. You need someone to look at the cervix and at least make sure that you've had a smear which is normal within the 3 years. If you haven't had one, you got to go to your GP, make sure you are within the window of, you have a smear in the interval that I've mentioned. Somebody's looked at your cervix, somebody's done the swabs. So take home messages. I cannot lay more stress on it. Please, please do attend every invite that you get to have your cervical smear. The aim is to prevent cancer, and that too in young women. We all know about Jade Goody. Smear is not that fearful as people might say. If you've got the 3 that I say, again, a comfy couch, a proper instrument, the procedure is very short and it can be dealt with in minutes. So you can always request for a smaller size speculum if discomfort, but I really don't want you to give me any excuses for not having the smear done. And get a referral to the hospital. I'm quite happy to do a smear for you if these amenities are not provided to you in a GP surgery. But I really, really want the smears done at the proper intervals. And I hope that today's talk inspires you. You're going to inspire a few more. And together, we women will beat cervical cancer. Thank you.
Thank you so much, Debjani. We actually have a question for you. So a listener said, age 37 and tried to have a smear 3 times, all failed attempts due to pain. Are there any options? Gynecologist last seen said risk was low and could possibly do over general. Is that a little bit over the top?
I think so. I'll tell you, the commonest problem in a GP surgery is that the couch is in, it's like a flat couch. You have to frog leg, somebody peeping in, maybe not the right size speculum. I would say try us. Let me try once and get a referral to a gynecologist just to have a smear first with a proper couch and a proper instrument before you have a GA. The only thing I would say is I've given GA to one woman, but there was an absolutely genuine reason. She was a virgin and she couldn't tolerate anything. Or she's not had sex for a very long time. GA is not over the top. I think what is not having a smear is not acceptable. It's very difficult for me to say because I think I'm successful with most women. I would just say give us a try.
Thank you. A comment from Marta as well says that physio can help women learn how to relax their muscles as well. So you have 2 options there, hopefully.
Yes.
If you could also help us with another query that relates from earlier this evening about PCOS. So one of the women wants to come off the pill, not because she wants to get pregnant, but it means she has no sex drive. And Mr. Nnochiri suggested a progesterone pill and an anti-male hormone drug, and she just asked whether they can be taken together.
I'm not sure. Anti-male hormone drug?
Yes.
I'm not sure what his. I'm really not sure what his meaning.
Oh, no worries. He mentioned it only in the evening, but we did make a note of it. So what we will do is we'll just message him.
Did he mean metformin? No, that's insulin sensitivity.
Yeah. No worries. We'll find out and we'll get back to the person. We don't have any more questions on smear tests, but thank you very much for going through it. Hopefully people listening will feel a lot more comfortable and confident getting a smear test. Thank you to all of our speakers, Mr. Nnochiri, Marta, and Debjani as well. Thank you everyone for your time and for attending. This recording will be saved so you can go back on it.